We're going to go straight into the cancers of the skin, and today we'll spend most of the time on melanoma. So why is it that melanoma is where we're going to spend most of the time today out of all the cancers of the skin? And the reason is that it's a number 5 and number 6 rising incidence tumor amongst women and men, respectively. So it's very common. And we'll address the little bit of anatomy of the skin will be touched here, the staging of melanomas, relevant clinical information will be addressed, and of course the imaging with PET-CT, interpretation basics, and staging, response to therapy assessment, and some little ant-mini cases will be shown. Just like I said, the incidence is on the rise. Majority of them will be detected in early stages, and thus the mortality is fairly low. So that's the good news, but not in everyone, unfortunately. And if you look at the key statistics, again, this is all available free at the Sears website. You will see the curious distribution of the age, when that most commonly appearing seems to be after the age of 50, but we see certainly virtually any age one can present with that fairly aggressive disease, particularly in late stages. How do we stage the primary lesion? The T-staging is quite interesting. It's done by few approaches. Breslow thickness of the lesion is measured by an ocular micrometer, and that goes from the top of the granule zone of the epidermis to the base of the neoplasm. So you're basically measuring in millimeters, and here is a little cartoon of that. You got then Clark's level 1, 2, 3, 4, and 5. The Clark's level 1 is just a granular cell layer. Below that is epidermis 2. Papillary dermis is 3, reticulodermis is 4, and of course once it goes out into the subcutaneous fat, usually that does not work very well for the patient's longevity. And that, in fact, translates very well into the prognosis. And you can see that a T-staging nicely breaks down the prognosis quite well.